Ketamine doesn't kill people, bad paramedics do, but that doesn't necessarily mean they deserve jail time. Today, we are discussing the Elija McClain trial. Now, I've got a couple other videos on this site discussing ketamine, excited delirium, my opinions on that, and some of the ridiculous legislation that Colorado came out with concerning this case that happened back in 2019. But today, now that the two paramedics involved are on trial, I really wanted to take more of a deep dive into this trial, what it means for us, and what I think about everything. Now, this is all my opinion. It does not reflect my employer or anybody around me, so I want to make that absolutely clear before we go further. Now, the second thing I'm going to say is that I'm not a lawyer. I'm not an expert in law, so I'm not really discussing a lot of the legal aspects of the trial, if that makes sense. I just kind of want to give my perspective as a paramedic and kind of talk about some of the things we've seen in the trial thus far. Similarly, I am not a news reporter, and I'm really not using this to like give a play-by-play of everything that's happening. You can find a ton of different websites that have kind of discussed this trial from start to finish on Instagram. The Real Pragmed has a good kind of rundown and a series of posts on everything that's happening in this trial, because it really affects a lot of us as paramedics, and it is quite a big deal as far as precedent goes. As a quick recap, back in 2019, Elija McClain was walking down the road with a ski mask on in Aurora, Colorado. Police confronted him and ended up going hands-on with him, bringing him down to the ground and restraining him there. Now, it is reported that one of the officers used a carotid hold, which is just briefly cutting off circulation to the head. They lose consciousness, let go, comes back. You know, there's a lot of controversy surrounding that. There's a lot of controversy surrounding whether the officers should have contacted him at all, let alone gone hands-on with him. But that's not really in the scope of this video. So essentially what happened, they go hands-on, they're restraining him on the ground, and because a carotid hold was used, they said their protocol was to call the Aurora Fire Department. Now, as a little bit of context, the Aurora Fire Department runs a paramedic fire service there. So they're non-transport. They show up in an engine, and they usually have 1 to 2 paramedics on board. And then Falck Ambulance is the private service that's contracted in that city to provide the transporting paramedics. Now, Falck generally runs with a paramedic and an EMT simultaneously. So they showed up on scene. A bunch of other stuff happened. Essentially, the fire medic walks up to McClain. We'll get into this a little bit more later, but he ends up giving Elija too much ketamine as a sedative. He identified what he thought was excited delirium, gave him 500 milligrams of ketamine, and they took him to the hospital. And when he arrived there, he was essentially dead, died 3 days later in the ICU at a UC Health facility. So there's a lot of stuff that's happened since then. The 2 officers were brought up on charges, and there were charges that stuck on them. And now the 2 paramedics are being brought up on negligent homicide, along with a lot of other indictments. You can go online and read all of those. This is a big deal for a couple reasons. Number one, the precedents of criminal charges related to patient care is kind of a scary one. The second thing is that ketamine is being villainized throughout this whole thing about whether it has a place in this. And then thirdly, it really shines a light on the negative aspects of paramedic care and what can go wrong if you are not diligent and or good at your job. So with all of that background out of the way, let's get into the video. Let's talk about ketamine and why I don't think Elija McClain's death can be blamed on ketamine alone, why I think ketamine is a safe med, and why I think this is more on the paramedics than it is anything else. So ketamine has a lot of different connotations. Like, a lot of lay people know ketamine as a date rape drug, and then they'll call it like, it's a horse tranquilizer, and it's a really powerful sedative. And there is some truth to that, right? Like, you can get illicit ketamine and use it as a date rape drug, but it is used a lot in medicine. You'd go to any ICU doctor, any intensivist, most EM docs are going to tell you they absolutely love ketamine as a medication because it can do a lot for you. At really low doses, ketamine is a powerful analgesic. It really helps relieve pain from just horrific injuries. The example I use a lot with this is we were on scene of a trucker that essentially got backed into by another truck, pinned his legs, and broke his femur into like 4 different spots. Absolutely screaming, writhing on the ground in pain, was just non-coherent, painful injuries. So I gave him some ketamine, and for the rest of the trip, he knew exactly where he was. He knew who I was, and he was happy as a clam. Even though he could still identify that his legs hurt, that they were broken, he was just like not in pain anymore. Now, that's pretty spectacular because another tool we have in our toolbox as paramedics is like something like fentanyl, which is a powerful analgesic. But anybody that's given fentanyl or got fentanyl for a severe injury knows that it makes the pain slightly more tolerable, but it's not getting rid of it at all. And you by no means stop caring about that pain. So we really love ketamine for severe pain management. The other thing it was used for a while until this case came out in Colorado was managing your super violently combative patients. Not the patient that's just really upset destroying a store, like your patient that's exhibiting signs of what we called for a long time excited delirium. So they're confused, they're really hyperthermic, really hot and sweaty, they're exhibiting super strength, and they're destroying stuff, all around them, and they're a severe danger to themselves and others. And it's a medication we like to use for that because it's a very fast onset when it's given in an IM injection. It works in usually under 5 minutes, where other alternative therapies like benzodiazepines will take up to 15 minutes to take effect. The whole reason we're giving a medication instead of just physically restraining somebody is because, generally speaking, it's way safer to inject somebody with a medication than forcibly hold them on the ground. Whether you're in the excited delirium is real and they are just going to die spontaneously on me camp, or whether you're in the excited delirium is completely false, I think we can probably all agree that we'd rather not be just restraining somebody physically and letting them harm themselves and other people around them. I'd much rather give them a sedative, make them happy, and transport them safely to the hospital for further medical care. That's another reason we give it. Now, that's what we're going to focus on today, but just to give more context in ketamine, ketamine is also given a lot for sedation. So procedural sedations and prolonged sedation, especially in transport environments, it's freaking great. So when we have somebody that needs to be intubated, they need a breathing tube put down their throat into their trachea to allow us to breathe for them. We're going to use ketamine as an induction agent. We give ketamine along with a paralytic. And these two medications together are essentially anesthesia. The ketamine will blunt the pain response. It will also put them to sleep. And then the paralytic, like rocuronium, is going to relax all the muscles and make things really easy to do. If you just gave the rocuronium, that's going to paralyze them and they're going to be totally awake. So we need a second agent. Some other meds that are used for this are like etomidate, but the profile of etomidate isn't quite as good, we're learning, as well as benzodiazepines, which are hardly ever done anymore. And why we reach for ketamine in this situation is because ketamine, with exceptions, has a smaller impact on hemodynamics. So while giving a high-dose benzodiazepine like midazolam is going to drop blood pressures pretty substantially, and it might even lower the heart rate a little bit, we're going to see with ketamine, it can actually increase blood pressure slightly, so long as they're not catecholamine depleted, and it will increase heart rate. Both of those things are good in situations where hypotension is very, very dangerous. Additionally, when we have somebody that is already intubated and we want to continually sedate them, a lot of times we'll see patients placed on propofol, which is a sedative. You guys probably know it as the Michael Jackson drug, and then given some fentanyl along with it to potentiate its effects. The reason we do that is because propofol has very good sedative effects, but it doesn't blunt pain quite as well as we would like. Now, I'll be completely honest. I don't quite understand how something can sedate you but doesn't stop your pain response. Just take my word for it. It does, and people way smarter than me have figured that out. So we always give something else with propofol to make them more comfortable. With ketamine, it's kind of 2-in-1. So if I only have a certain number of pumps on the helicopter, I can take off the propofol and the fentanyl and I can replace it with the ketamine drip. And it's going to do both the pain and the sedation for that patient. And then everybody's happier because the last thing we want is that patient waking up on our cot or being in any sort of pain. And we really like ketamine because, like I said, it can increase that blood pressure. So bear with me. I know this is a lot of background information, but I'm really sick of short form content taking these incredibly complex issues and just making them into a soundbite because it harms everybody. Like, it doesn't do justice to these issues. It doesn't do justice to these problems. And what we're seeing here is a stigma against ketamine. So back to the topic of ketamine as sedation for severely agitated patients having a psychiatric emergency. Now, psychiatric emergency, not a behavioral issue, not somebody that's just being an asshole ransacking a store. This is somebody that is a true threat to themselves and others. They are going to injure themselves. They're going to injure those around them. Ketamine was oftentimes picked because, one, we oftentimes can't get a blood pressure on somebody that's dangerously combative. It's not going to be very accurate. And a lot of times we cannot really get a pulse on them either, just because it's dangerous to do so. We might be able to get a quick one, but like sitting there for 15 seconds counting my watch probably isn't going to work super well. In these cases, we'd reach for ketamine because it's fast onset. So the shorter I have to hold on to this patient, the better. And second, I have a better chance of this medication being received well by their body. Like, I'm not tanking an already low blood pressure. I'm not bottoming out heart rate or anything like that. So we'd reach for ketamine. Now, an important part of that is that ketamine can cause hypotension. And we oftentimes forget about this as providers, is that just because it's more stable doesn't mean it's just this be-all, end-all, will never cause any harm to a patient or cause anything to go bad. So the important part is we sedate them, and then we immediately have to start caring for that patient. We have to immediately start going through our vital signs, monitoring the patient. I always use capnography on any patient that's getting any kind of sedation, even pain meds. I'm going to put a nasal capnography device on them to measure their breathing, which is a good indication of perfusion as well. So we have to do that. Now, I want to back it up just a little bit, because just because we can't get a blood pressure or pulse on the patient before we sedate them doesn't mean that we're not going to assess them before, right? Like, we're going to look at this patient. We're going to say, like, oh, do they need this medication? Is this the appropriate medication for them at this time? Is it safe to give it? Do they have an airway? Are they breathing? Do they have a pulse? Like, if they're moving around, they have a pulse, right? So we still need to assess our patients before we're giving the medication. Now, pay attention to this. This is all going to be important in a second. When it comes to these two paramedics, essentially what we have found in the trial, now granted, there's what's coming out in the trial, there's the truth, and things are probably somewhere in between everything, because you have two sides trying to plead different cases. But essentially what we think we know is that they showed up. They didn't really assess Elija McClain on the ground, who, according to body cam footage, was like barely even struggling for like the 2 or a couple minutes before the paramedics arrived on scene. And then they injected the ketamine. They gave the wrong dose of ketamine because a multitude of reasons that we'll get into. And then they didn't monitor the patient. There's a lot of throwing under the bus by both services right now, but essentially it looks like there was no monitoring placed on the patient afterwards. Airway was not reassessed. There was no vital signs taken. In my opinion, that is absolutely horrible patient care. And it looks like what happened is that ketamine probably was in part responsible for Elija McClain's death. I feel pretty safe saying that if McClain hadn't received that ketamine, he probably wouldn't have died. But that doesn't mean that ketamine is this danger med that's just killing people left or right. What it means is that as paramedics who are giving potentially volatile medications all the time, we need to be aware of the side effects. So side effects of ketamine, we might cause hypotension, which we can intervene on. We have fluids. Every paramedic ambulance that I know of carries some kind of pressor. It might not be the best pressor ever, but most services are going to have dopamine on board at least, which is way better than nothing. We've got fluid boluses we can give. Some services have push dose epi or dirty epi drips, like critical care services are going to be carrying a lot more than that. So we can intervene on hypotension. The second thing that might happen is it might cause them to go apneic. It might cause them to stop breathing. This sounds really scary to a layperson. Like, oh man, you're giving a medication that might stop somebody from breathing? All the time. Fentanyl can stop people from breathing. Midazolam can stop people from breathing. We carry a ton of meds that can do that. And really, it's not that big of a deal. A large portion of my training as a paramedic goes into airway management. At the very basic level, I'm trained to adjust somebody's airway. So I can do a jaw thrust, head tilt, chin lift. I can reposition the patient, turn them on their side if it's safer for them for aspiration. We've got suction. We can suction the oropharynx, the nasopharynx, get any secretions out of there, stop any kind of aspiration. We've got nasopharyngeal airways, oropharyngeal airways. Next step up, we have supraglottic airways like eye gels. Next step up, we've got endotracheal tubes. And the next step up from that, if like all else fails, we have a surgical cricothyrotomy we can perform. So I've got all of these interventions in front of me, not including administering oxygen. We can do that too. And if somebody stops breathing, all I do is I can put a nasopharyngeal airway in and I can breathe for them on the way to the hospital. I can throw in an airway. I can make this a very safe environment for the patient, even though it seems like it's a big deal. In the grand scheme of things, it's not. We can manage those potential side effects. And that wasn't done. There was one report in the trial where one of the EMTs on scene or another provider on scene saw Elija McClain being loaded into the ambulance and think he saw like vomit on his mouth. Like, I've got a supine patient on the cot with vomit in his mouth. Like, that's pretty darn concerning to me. So the moral of that story, in my mind, granted, my opinion, right, is that we have to be good providers. And it is totally ridiculous to look at ketamine and say this isn't a viable tool. I don't know why it's getting like the blame. Maybe it's like the easy target. Like, granted, the paramedics are getting the blame too, right? They're the ones on trial for negligent homicide. But like a big part of this is like ketamine villainization. So we've got like state legislature that now says we can't administer this in a variety of different situations. We've got a lot of different restrictions on that. And I just think that's absolutely ridiculous. So let's go back to the whole overdose portion of this. The two fire paramedics gave Elija McClain 500 milligrams of ketamine when he weighed 80 kilograms. So let's break that down a little bit. Now, I couldn't find Aurora Fire's protocols online for ketamine administration prior to 2019 when they were still allowed to do it. But what I can tell you is that protocols that I've worked under in the past have given me a range of like 2 to 4 milligrams per kilograms IM injection, which means following, let's say the 4 milligrams per kilogram, because that's an accepted dosing scheme, we'd be looking at between 300 and 400 milligrams for Elija, where higher doses would be for much heavier patients. I think they were saying in the trial Elija should have weighed like 200 plus pounds for 500 to be an appropriate dose for him. Here's one thing we know about ketamine is that if we give small doses slowly, it causes this analgesic effects. The patient stays conscious. We've got actually a pretty minimal chance of complications. We give that ketamine faster. We give more of that ketamine, and what it's going to do, it's going to disassociate them, which is what we want to do a lot of times. We want to knock them out, pull them out of their body and make them not care about the situation. But generally speaking, we're going to be putting in a breathing tube when we do that, performing intubation. And if we give more of it, that doesn't necessarily give us toxic effects. It does raise the chance of complications slightly. However, what it's going to do is it's going to make the ketamine last longer, which is kind of an interesting trait in ketamine. If we're giving higher doses faster, it's going to take longer for the effects to wear off the patient. In the autopsy, one of the reports said that Elija McClain had therapeutic levels of ketamine in the blood, that it was not like toxic levels to cause death necessarily. And what this tells me, and once again, my opinion, is that ketamine didn't kill Elija McClain. Bad patient care after the administration of ketamine did. Is that overdose significant? Yeah, it is, because it really highlighted some bad training for these paramedics and some bad care practices. So what they're essentially talking about in court, and one of the testimonies that I read from one of the paramedics, is that when they were trained, they were trained small, medium, large doses. Like small was 300 milligrams, medium was 400 milligrams, and large was 500 milligrams. And they're saying that, well, it looked like he was struggling really bad. So the paramedic decided to up it to 500 milligrams. Do I necessarily believe that? No, I think that it was just a med dosing error, overestimation of weight, and the wrong dose was given to him. But it really does go back to that training, right? Because nobody doses meds at small, medium, large, especially when you're given a kilograms in your protocol and training. Like, you need to be going off of the kilograms. Now, kilograms is estimation, right? In these paramedics' defense, Elijah, I believe he had a puffy coat on and he's being held down by 3 officers. It's going to be kind of hard to get a good, accurate weight on him, but that doesn't really excuse the sloppiness of it, in my opinion, in this case. And once again, it comes back to monitoring the patient afterwards. So the last thing I want to discuss in this video is the criminal case being brought against these 2 paramedics. Historically, negligence cases in the medical community have been civil. They're rarely brought criminally, and I do believe this is going to set a precedence. Now, there are going to be a lot of people that have really strong opinions one way or the other, and I'm going to be completely honest, I don't entirely know what to believe. I've got like inklings here, and I've got worries at the other end of the fence, but I'm not like steadfast in my convictions for this. So if you have an opinion, I'd actually really like to hear you voice that in the comments down below. In this case, they're being charged criminally. Now, I think it's a foregone conclusion, for me at least, that neither of these paramedics should ever be paramedics again. I'm fully in support of civil suits and settlements, and that family getting some kind of monetary compensation, as shallow as that is. Like, they need something, because ultimately what happened to their son was absolutely egregious. As far as criminal cases go, though, I'm worried that this sets a very dangerous precedence for medicine in general, not just paramedics, although this one does relate to paramedics more. And the reason I'm so worried about that is because where is the line? And maybe there's a clear delineator that people see, but I guess I don't see it. So it was bad patient care. They violated protocol. They did not do what they were supposed to do for McClain, and it resulted in his tragic death. What level of meta error is going to be treated criminally in the future? What level of not knowing my protocols or going off the protocols is going to be considered criminally? So in my case, like, I've definitely had med errors in the past. They're really common in medicine, and we have a way of dealing it with, like, we admit our med errors freely when they happen. We generally don't face disciplinary action for them. We present on why they happened. We talk about how we could prevent it in the future, and usually some kind of system is put into place to counteract med errors in the future. As far as I know, I've never had a med error that's resulted in the death of a patient, but I'm worried that if somebody makes a med error like that, and it truly is an accident or the result of bad training, whatever, I'm worried about that having that criminal liability over their head and encouraging people to cover it up. So this reminds me a lot of the Redonda Vaught case, where she gave vecuronium and killed a patient in a CT scanner when she thought she was giving midazolam for anxiety, where I think she was a terrible nurse. I don't think she should ever be a nurse again. However, I'm really not in support of criminal charges against her, because once again, that precedent is set. People are going to disagree with me on this, but it is kind of a scary prospect, knowing that if I misread a protocol or in the heat of a moment, I screw something up and it results in the death of a patient, that I'm going to be brought up in criminal court and could face jail time taken away from my family for a prolonged period of time. And, people are going to be mad. They're like, well, if you're a good paramedic, you won't do that. Like, anybody that's actually worked in medicine for any period of time knows things happen. Like, I've seen really, really good providers have med errors. I've seen really good providers make mistakes or misinterpret a protocol or have bad things happen, and that doesn't necessarily mean they're bad at what they do. Hospitals, med errors all the time. So I digress a little bit. On one hand, I get it. These paramedics showed up to a very dynamic scene where there was a lot of tensions already, right? They've got this kid on the ground being forcibly restrained. The officers are pretty amped up. Like, it's late at night, it's dark, they're walking into this weird scene, right? And That's hard when you're quite literally a second responder. When you're coming into the scene that's already like started, you don't really know how it started. You don't really know how it's going to end. And now you're being like injected into the middle of it and trying to like figure out how to, work with all the different agencies on scene. That's complicated. As a medical provider, though, you have to be able to kind of discern what's going on, assess your patient, and as a paramedic, you are probably the medical authority on scene. You're the person that knows what has to happen for that patient, and you have to advocate for them. Your job is to provide medical care. So regardless of what law enforcement wants you to do, you can definitely take that into account, like listen to what they're saying, but at the same time, you have to make your own decision for that patient. If you are unable to overcome that pressure that other agencies around you might be putting on you, you probably shouldn't be in this profession, is what I'm going to say. So on one hand, I get it. Dynamic scene. I've definitely been caught off guard. Your dispatch is something kind of piddly and you get there and you're like, oh crap, what's going on? Like everybody's yelling, people are mad, like there's people getting restrained, tased, whatever it is. But you still have to be able to kind of get through that fog of war and figure out what's actually going on. And remember, your job as a paramedic is never disciplinary. Your job is purely medical care and doing what's right for your patient. No matter what they've done, no matter who they've hurt, like your job is medical care. So I'm going to leave you with that. If you have any questions about this, leave them in the comments down below. And I will see you next week.